Hi, my name is Eva Steiner, and this is my project Psychotherapists Around the Globe. I am interviewing the psychotherapists around the world and asking them the same 8 questions. I am wondering how mental health profession is in their country. Today we are going to. Thank you for doing this interview with me. Before we start, can you tell me a little bit about yourself?
Thank you, Eva. My name is Jennifer Male. I am a clinical psychologist, but I come from a medical background, public health, health promotion. I'm excited to be contributing to the mental health fraternity globally.
Thank you. So let's start with the first question. Tell me a little bit about your culture. What is some holiday or traditions that your country celebrates? And if your culture would be an emotion, which emotion would it be?
Uganda is diverse. Uh, we have so many tribes, over 53 plus tribes. So every tribe has its own traditional festivals, but what unites us as a country is our Independence Day, that is 9th October. The different cultures also are interdependent. For instance, if Buganda Kingdom has a festival, Busoga Kingdom, Toro Kingdom will come in to join in. Like recently, this year we had a royal wedding in Busoga Kingdom, and everybody joined in. It was a joyous moment. The emotion for Ugandans is happy, happy, happy. Ugandans are happy people. Ugandans are kind. They're compassionate. Globally, we are the second largest hosts of refugees after Turkey. So you can't live with refugees if you're not happy, compassionate. That's what we are as Ugandans.
Hmm. And you mentioned there is a lot of tribe living under the same roof. So I want to just understand a little bit more, like how you interact, how are the different interactions. You're coming together for this Independence Day you mentioned. So can you tell me a little bit how it's living, with such a diversity?
Diversity is what makes us strong as Ugandans. The most important thing is tolerance. We are able to tolerate each other. We are able to understand and appreciate each other's differences. The central and the western and the eastern part of Uganda is made up of the Bantu groups. As you go up the north, we have Nilotics, then we have Hamites somewhere. They are all different in terms of economic activities. Like in Western Uganda, they are predominantly into cattle rearing. When you come to Central, it's about farming, coffee farming, banana farming. When you go to East, part of East is the same as what is happening in Uganda, but when you go to the other part of the East, they're the same as West. They're into cattle rearing. So we are diverse, but we have things that keep us together that are synonymous, things that are the same. In as much as I could be a Muganda, you find that there's something about me that is the same as somebody who is a Musoga. And as I look at my culture, there are things that are actually the same as people that are from northern Uganda, that are actually people from Western Nile. So we combine the things that bring us together to solidify our unity as a country, and then we tolerate and accept each other for our differences.
I think that's also super important for therapy, huh?
Yes,
Working with different tribes. Yeah.
very important because you see, therapy in Uganda had an issue with HIV and AIDS from the 80s through the 90s. So the way the counseling profession came into the country was to support that. So it was associated with HIV and AIDS. So it was support for people that are living with HIV, diversifying it now into like real professional work to tell people that, you know what, you can come for depression, you can come for life crises, was something that we needed to now teach the nation, for people to know, oh, it's not just about HIV, but I could actually go for something else. That was one. Number two, the cultural context, the way Africans perceive mental health, their coping strategies, the way they would want to soothe themselves. So, for instance, if I have to tell a client, what is your self soothing habit, you could find that it can't be like the Western approach. So what we're trying to do as therapists is to integrate the culture aspects, the things that we do as Africans to help manage our mental health and to enable us relax, enable us cope better. And then the therapy is not supposed to make us lose that bit. So we carry it along. That's why I appreciate your question of the culture differences.
How did you become a psychotherapist in your country, and what is your therapeutic approach?
Like I said, I come from a medical background and public health promotion. In 2018, I had a project of designing programs for workplaces, programs that enable employees to live a healthier life. And when I ran these programs, I started with surveys. Being medical, I went thinking issues had to do with nutrition, physical activity, health education, being a health educator. But what really struck me was the fact that most of the issues had to do with mental health, burnout, stress, depression, anxiety. And then I had to now start developing mental health related programs. So that was my first interface with mental health. And as I read about it, I got the interest. I enrolled for a master's in clinical psychology. And going into that course also opened more doors into my own life, looking at areas of trauma, looking at different things. And also being medical, I was able to relate what we're not doing right in the hospitals in terms of patient care. Yeah, it's been nice. It's really broadened my approach to helping people. And I have a special love for trauma. I also have something on maternal mental health, where I support mothers across the continent, like women's mental health, from the adolescence, actually, from adolescence, the reproductive age, to perimenopausal, menopausal, and postmenopausal, because that all of that comes in the context of women's mental health. I've also developed something on fertility, because when you're dealing with that, then fertility becomes an issue. And when you talk about fertility, of course, you're going to deal with couples. So I also do couples therapy because of health promotion. I'm also into chronic illnesses, especially managing people that have been diagnosed with chronic illnesses cope better. Being medical, you know the disease process, you know the etiology. So you bring in the psychological approach to help people cope better, to accept and then live meaningful life, even if they have a chronic illness. I also do individual sessions for depression, anxiety, life crises. Yeah, I have a broad spectrum. Yeah, but I'm enjoying it. I love it. So the approaches
Yeah.
I use for trauma, EMDR, psychodynamic approaches, CBT. I also love the internal family systems. I love using the somatic approaches, the parts work. I mean, psychoeducation is something that I really, really love because when people are empowered, when your prefrontal cortex is empowered in form of knowledge, it means that you're creating a barrier that can help you manage a lot of information that is being ingested by your brain.
And in general, in Uganda, you need to be medical profession to work with people, or there is a profession as a psychologist or psychotherapist. So how is like official road to psychotherapy?
In most cases, you don't need to be medical. Most people start off by being counselors, like having a bachelor's in psychology. Then they go ahead, either you become a counseling psychologist or a clinical psychologist. That is the path. But for me, because of that exposure and the fact that I was coming from, I got the exposure to mental health. I decided to venture into it, to combine it with my medical profession. But majority of them are not medical people.
How society looks upon psychotherapy or any psychological help?
Like I shared with you, Uganda started the understanding the profession of counseling. They knew about counseling, but they didn't know about psychotherapy with the support of people with HIV. So it was associated with HIV. So there was stigma around it. And then, of course, our country is very religious. Many people are Christians. So they'll go to see a priest, they'll go to see a reverend for counseling, for spiritual counseling. So they've no need for that, but they didn't know about the professional counseling. It was after COVID. Well, it was there, but it wasn't something that somebody would want. I see that even in my line of work, many patients will come to me and they're like, I've never done this before. What is it? How does it work? Somebody told me I need therapy, but how does it work? So there's still a knowledge gap and a bad attitude about psychotherapy. However, what we need to do is to continue orienting the different settings, like schools, like hospitals, like churches, so that we have professional psychotherapists entering the different spheres.
And you mentioned something super interesting to me earlier, that maybe the intervention shouldn't be the same as interventions of the West. So you combine a little bit your culture with the psychotherapy. Can you tell me more about that? Like, what do you do?
For instance, we borrow the knowledge, we borrow the approaches, but when it comes to, for instance, group psychotherapy, in Africa, men don't talk about their problems with women. So it is best to get men alone and women alone. So if you're going to do group psychotherapy, you have the men sitting alone and the women sitting. There's a culture, for instance, in Eastern Uganda. If you went there and you mixed a group of men and women, you will not get any feedback. The women will tell you, as the husband I said, that's what I also say. So you need to get them and separate them from that sort of arrangement to an arrangement where they're free to speak. That is one. Number two, I talked about for instance, the self-soothing practices. Here in Africa, people love gardening. For anger management, we have local ways. If somebody went and split firewood, it would be a way of managing anger. In most cases, people have a mortar for grinding, maybe groundnuts, you know. When we went out to the elders to talk about why they had certain equipment in the home, they said it's called chinu. It's a mortar, you know. It helps you to crush the genets. So, for instance, if a mother in a home is angry with a father, when she goes to crush her genets, she will be able to soothe herself while doing that activity. By the time she comes back, the anger is gone and they can have a meaningful conversation. Different ways. We have, for instance, fireplaces. Traditionally, we had what we call the informal learning. So, for instance, if you have to go up country and you want to meet people there, it would be interesting for you to have like a fireside chat. You have the fire where they used to do informal education, and now we are talking about mental health. What is mental health? What is anxiety? What is depression? It would be more meaningful in such a setting.
What is your society teaching about child-parent relationship, and whether these values of society also influence how you design your interventions as a therapist?
In African society, in Ugandan culture, our families have a lot of hierarchy. We have the hierarchy of the father is the head, the mother is like another boss of sorts, and then the children, like in the lower tier. So that hierarchy in most families is dad, you don't talk back to dad, you don't say this to your dad. So the hierarchy in most cases is reinforced. You see it growing up. It is like a silent way of conditioning you. So many times when I get teenagers, children, in most cases when a child has a problem, you know that there's a problem at home. Of course, you have therapy with a child, and then you have to engage the family. You need to engage the father and the mother. Of course, the hierarchy in most cases is out of denial. The mother might be for it, the father might not be for it. You can have a case where the child has an issue, the mother is for therapy, and the father is like, I don't want my child. going back to see the therapist. And because of the hierarchy, it's also going to affect that access to help. And that means that
Mm-hmm.
fathers, in a way, are going to lock up a lot of issues in the family because or either people are going to see you behind their backs, and probably the father could be the primary, maybe abuser, and you can't get to him because of how the family is structured. So, family structure is something that is very strong in our society, and it affects how we also move or intervene with our psychotherapeutic approaches.
And you also mentioned that men are raised like don't talk about your emotion. Can you tell me more about that and how that influence, like if you get a male client?
The society would tell a man that a man doesn't cry, a man has to be strong, a man must never show emotion. And even when they come, in most cases, they struggle to express themselves. But it's important in therapy to create a platform or a safe space for them to just be, to keep encouraging them. Well, it might take you longer for a man than a woman, but you have to keep encouraging this person to just talk, to just be themselves, to know that, whereas I'm a man, I'm also a human being, and a human being has emotions, and these are my emotions, and I own them, and they are mine.
And in general therapy, is it available through public health system or it's a private pay?
It's not yet available through the public system. It's only available for the mental hospital or the mental facilities. Parliament is trying to enact a law that can make it available. We saw the need during COVID. There was an influx of patients in hospital that needed help. They were not like mentally ill, but they were struggling. Their mental health had been affected, and we needed to now go back and create another system or reinvent the system to ensure that we have psychotherapy as a part of it. But most of it is private, and that means that issues of access and also costs many people cannot afford. Also, because we have a refugee population, we've also had we had also the northern part of the country being affected by the war. So there were priority areas that were given mental health assistance. The HIV patients, the people in the northern Uganda, there was many organizations that were going up there to do trauma therapy and psychosocial support, and then also the refugee settlements. But besides from that, the normal population does not have free access to psychotherapy services. So that means that we need to do some systemic work in terms of policies, in terms of looking at schools, what happens in schools. Every school must have a counselor, and it's not just a counselor who is sitting in, but also the Ministry of Education integrates mental health education in the curriculum. Just like we have gardening as part of science, we have reproduction as part of science. I think an emphasis on mental health is very important as a subject. I have recommended it for the medical profession, the people that I've met that are into designing curriculums. I've encouraged them for doctors, for nurses, for medical people, allied health professionals. They should have an element of mental health education because most of the diseases are connected to our mental health and our psychological predisposition. So it's a big issue.
Mm.
And then also coming back to, say, the health system, if we have the different cadres and we have the different, because the way Uganda's health system is designed, it is sort of like a decentralized healthcare system where we have health center 2, 3, 4, 5, then a four, then a district hospital, then a regional referral, and then the national referral. We should be having different cadres of mental health professionals at different centers, just like we have the doctors, the nurses, so must we have mental health professionals. So there's a lot of work to do in terms of blending in the mental health services across the spectrum, especially in education and in health. And also pastoral work, religious work, because I told you that Ugandans are religious, some are Christians, some are Muslims. So if we have our services embedded in the different spheres, we can be able to reach out to many people.
So I assume here, so if the help is available in the hospital, then I assume that as a client, you are able to have a few sessions, but then you go home. It's not like a longer process.
Yeah, so currently most hospitals have psychologists or clinical psychologists as maybe part-time staff, and that is for patients that need it. But because of costs, somebody can do one session, depending on how much they can afford. There isn't like a structured way of people accessing care. And also, maybe insurance companies can say maybe we'll give you up to 2 or 3 sessions, but that is also not sufficient because if a person has like depression, they need about at least more than 6 sessions for them to be able to overcome whatever they're going through. So we still have a lot of advocacy work to do in terms of who funds the care.
What are the learned beliefs regarding client therapist relationship, and can the relationship continue outside the therapy once the therapy process is over?
What is important between the client and the therapist is the therapeutic alliance, the therapeutic relationship. It helps a lot, but most of the work in this relationship has to be work done by the therapist. You need to work on yourself in terms of your attachment style. You know, if you have, say, an anxious attachment, you might find yourself overly involved with clients or fearing for clients to leave you or fearing to let go. Managing your boundaries as a therapist to know that this is how far I go with a client. Of course, clients can text you, they can send you a WhatsApp, but also you can't say, I can't meet you outside therapy. I could meet you, but I must have my boundaries, knowing when to do what. When is it flexible? When is it elastic? When is it a fluid boundary where I have to go up and above for a client? And when does it have to be fixed? And when does it have to be flexible? So that is an art that you learn as a therapist in terms of managing your client therapist relationship.
Okay, and is supervision a must for a therapist in your country?
Yes, supervision is a must. We have the Uganda Counselors Association. It oversees the therapists in the country. It does the training. We've just finished something on EMDR. They keep inviting in groups of professionals and experts to train the therapists. Supervision is a must. Then also personal therapy and mentorship is also something that they recommend, but it's up to you, the therapist, to look for somebody to mentor you.
And in case of therapeutic abuse, so in a sense, like if a therapist cross the boundaries or lines with a client, can a client report that somewhere or not yet?
The client can actually report you at the Uganda Counselors Association and can face disciplinary action. It is something that we have in our country.
And what are the most common complaints that the client come to therapy for?
I've seen a lot of trauma. I've seen a lot of depression. I've seen a lot of anxiety. Then life transitions are actually very common, but mostly trauma, depression, anxiety.
Can you tell me more about trauma? What are you witnessing?
A lot. Remember, trauma is something that happens to you that it is like a wound, an emotional wound that you have. And majority of the people experience trauma in their family dynamics. There's trauma that can be associated to the adverse childhood experiences, issues of physical abuse, emotional neglect, physical neglect, sexual abuse. divorce of parents, incarceration of a family member, drug and substance abuse in the family. Yeah, so that category, I see a lot of physical, sexual, domestic abuse in many people's lives, you know. They come in with anxiety, they could come in with depression, but behind that, there's a predisposition of trauma. So, depression, what I can say is that depression and anxiety, from where I sit, are only symptoms of something bigger. In most cases, when you explore more with a client, you find that at the heart of this depression, at the heart of this anxiety, there's actually trauma. And majority of the people, out of the 10 adverse childhood experiences that I've talked about, SCs, majority score like 4 to 5. So they'll be having the depression, but they'll also be having physical illnesses. That is what I've been able to see. But also, there's a bit of the other covert trauma, the things that we don't take very seriously, like negative comments about you, the small things that we ignore that then pile up to be actually very traumatic. I also see that, but mainly I see a lot of people with SCs.
And you also mentioned earlier burnout and stress.
Stress and burnout are very common among the working class. Of course, what we've been trying to advocate for is workplace mental wellness programs that are proactive, that are personalized, that can foster good mental health practices in workplaces, that can help people address the drivers of stress in the work, which include job design, job support, issues of relationships, growth, finding meaning in work. Some people have been working in certain roles over and over again and now they've lost meaning. Managing life transitions, even in the workplace. I've hit 40. I've been working in this role for 10 years. I think I'm stagnated. How do I transition into a new career? It can be very stressful. I'm not remunerated enough. I don't have work life balance. You know, all of that causes stress. And you have this chronic stress syndrome. Of course, burnout is going to happen. And then physical illnesses, and then the vicious cycle continues.
If you would share one tool, belief, or approach that is a must have for you as a therapist, what would that be?
Compassion, 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 because I see a lot of trauma. Sometimes you, it can be a child, and you find that the perpetrator is the parent, and the parent comes to you. And then when you also, because I use a lot of art therapy, when you see the parent is also traumatized. So it is like transgenerational trauma being transferred from one generation to another. And when you put on your cape of compassion, you're able to work with the parent, work with the child without any feelings of judgment, without, you know, looking at them as people that deserve the care and should get the care in a safe space.